current product, Dr. James L. Araujo, who is Assistant Professor of Medicine in the Department of Internal Medicine and Director of Clinical Research in the Department of Gastroenterology and Hepatology at Downstate. Dr. Araujo had his MD, his medical doctor's degree, from the University of Pennsylvania, followed by residency in internal medicine at New York University in Manhattan, and he completed clinical and research fellowship training in gastroenterology at Columbia University. So he is a solid New York product that we are very happy to learn about from a solid New York product. The investigations conducted by Dr. Araujo have been published in several various journals and include aspirin therapy in patients with esophageal cancer and acute liver injury in the setting of over-the-counter weight weight loss supplementation. Dr. Araujo is a winner of the Digestive Disease Week Poster Competition of the Week and serves as a reviewer of the American College of Gastroenterology Case Reports Journal. Please join me in welcoming Dr. Araujo as we learn about a disease which perhaps before he says his first sentence, I can tell you was startling to me, because I learned in preparing to introduce him that as many as 85% of a given population, 85%, is afflicted with Helicobacter pylori infection, and many of them appear to be asymptomatic, but many others are symptomatic and have nothing done for it. So we're learning about a current problem in humanity from a scholar in humanity. Welcome to Medical Grand Round.
Thank you for the introduction, and thank you for the invitation to speak here today. So I'm one of the GI attendings at the VA over in Brooklyn, and the topic I decided to speak about is H. pylori, and the title is H. pylori, 35 years later. And of course, H. pylori has been around for much, much longer than that, but it's been 35 years since the discovery of the organism. And so I thought it'd be an interesting topic to talk about, especially since just this year and last year, newer guidelines have come out on diagnosis and treatment of the infection. So here's an outline of what I'll be talking about today. Firstly, just the discovery of H. pylori. I think the story of the discovery is an interesting one, interesting to share with you guys. The epidemiology, how the organism actually survives the gastric milieu, and how it causes disease, and finish up with the newest guidelines on treatment of the infection. So these two individuals are credited with the discovery of H. pylori. So on the left is Barry Marshall, and on the right, Robin Warren. And Dr. Warren was a pathologist in a hospital in Australia, and Dr. Marshall, his clinical fellow. And back in 1982 is when they made the discovery of H. pylori, and then spent the next several decades continuing their studies of the organism. So it was Dr. Warren who submitted a letter to the editor of The Lancet back in 1983, a year after their initial studies, where he wrote, "Dear Sir, gastric microbiology has been sadly neglected. Half of the patients coming to gastroscopy and biopsy show bacterial colonization of their stomachs. During the past 3 years, I have observed small curved and S-shaped bacilli in 135 gastric biopsy specimens, closely associated with the surface epithelium, both within and between the gastric pits. And in this, in these first two paragraphs, he already describes a lot of what we know a lot better about H. pylori today. He goes on to say that the distribution of the infection within the stomach was continuous, patchy, or it could even be focal. It may be present in any part of the stomach, but they were seen most consistently in the gastric antrum. How the bacteria survive was uncertain to the two of them at the time. He says the stomach must not be viewed as a sterile organ with no permanent flora. Bacteria in number sufficient to see by light microscopy are closely associated with any active form of gastritis. And he says that these organisms should be recognized and their significance investigated. So this is really their sort of landmark letter to the field of medicine that we really need to be paying attention to these organisms. He even provided some images in that letter of the organism. Here is the sort of S-shaped bacillus, which appears to be dividing. Dr. Marshall, in that same volume of The Lancet, wrote a separate letter, an accompanying letter, where he talks about these spirochetes of the stomach. These spirochetes that have been around since the 1930s, or at least sort of written about since the 1930s. So there is a 1938 article that he quotes where there were these spirochetes noted in 43% of stomachs at autopsy. And at that time, most of these specimens were unsuitable for diagnosis. 2 years later, there were these, again, spirochetes noted to be colonizing tissues near ulcers in 37% of gastrectomy patients. But these organisms were felt to be non-pathogenic opportunists at the time. And then in 1954, they were felt to be just oral contaminants, which multiplied in post-mortem species or were found close to ulcers. But they sort of had been discounted all these decades before. And it was Dr. Marshall who said, and sort of alerts the medical society, that we have cultured the bacteria from antral biopsy specimens on moist chocolate agar. These bacteria are shorter, with only 1 or 2 spirals, and resemble more Campylobacters rather than spirochetes. And these bacteria do not fit any really known species, either morphologically or biochemically. And so what were thought to be spirochetes appeared to be a little bit more similar to Campylobacter, but not quite. A year later, these two authors published some of the associations of this organism with gastrointestinal abnormalities, gastric ulcers, 77% of patients. Duodenal ulcers, 100% of the patients they saw had this association with this bacterium. Gastritis, duodenitis, a few other abnormalities were noted. So then Dr. Marshall, again, this is his, Dr. Robbins' clinical fellow, decides to prove a causative effect of Campylobacter pylori, the causative effect of its infection on the stomach. And so he tries to prove Koch's postulates. And there are 4 criteria you have to meet to prove Koch's postulate. The first is that the organism, the bug, infects diseased hosts, but not healthy hosts. And they had already sort of identified that. They identified the organism in patients with gastritis and peptic ulcer disease, but not healthy hosts. The bug is isolated from diseased organisms, diseased humans in this case, and grown in pure culture. So they, again, had already proven they were able to culture the organism. The cultured organism causes disease in healthy organisms. So how did he prove this? So they found a healthy volunteer, which actually happened to be Dr. Marshall, who drank the culture media and developed pretty soon after an acute gastritis. And the last postulate, which he wasn't able to actually prove, was that the bug is re-isolated from an inoculated host. And the reason he couldn't prove that was because he, very soon after developing this, gastritis, took some antibiotics and cleared the infection. So almost came to proving Koch's postulate. After that, there were these additional tests that could now prove this infection within the stomach. You take some biopsies and you do this, what was then called the CLO test. CLO stands for Campylobacter-like organism. So even back then, they already acknowledged that it wasn't quite Campylobacter, but something similar to it morphologically. Since then, you know, back in 1983, the organism finally got its official genus and species, Helicobacter pylori. This is sort of an electron micrograph of the organism. And you know, since then, there are over 50 different species of Helicobacter. I don't think it's an all-inclusive list, but the red organisms are ones that have been found to be clinically significant. You may have come across Helicobacter helmanii, which is another species which in very, very rare cases is science. Yep, okay. What is the global prevalence of H. pylori infection? Out of curiosity, I just want to see what the group thinks. So 65%, 38% of the group thinks it's 65%. So the actual answer, the global prevalence of H. pylori is about 50%, but we'll go into a little bit more about some of the finer details about that. So another interactive question, all of the following are associated with increased risk of H. pylori infection except oh, wow, okay. Shorter height. Something about shorter height that makes the audience convinced that that's the answer. So the actual answer is owning a cat, and we'll go into a little bit of why that, or why, you know, the epidemiology of all these things, actually. So, so H. pylori is the most common chronic bacterial infection. It infects 50% of the world, and that means about 4.5 billion people worldwide. It's acquired at a young age in developed this colonization first began. We know that the sort of genotypes of H. pylori have changed when we look at before Columbus and present day in areas specifically in Australia and North and South America. The genotypes have changed, and there's suspicion that these differing genotypes may actually impact the risk of developing gastric cancer around the world. The worldwide prevalence is quite variable. If you look at the US, depending on what article you read, prevalence can be anywhere from 15% to about as high as 70% based on zero prevalence rather than some of the other studies that we use. So when we look at the regions around the country, around the world, Africa has the highest prevalence. Latin America is sort of in order of prevalence, from Africa being the highest to Oceania, the lowest prevalence. When they look at the numbers, you know, between 2000 and 2016 and compare that to the late 1970s and early 90s, the numbers in Latin America and Asia seem to be stable compared to Europe, North America, and Oceania, where the prevalence has actually declined. When we look at infection prevalence based on patient age, we see that prevalence tends to increase as patients get older or as people get older. And seems to be a trend pretty consistent no matter where you look around the world. These are all just different countries, and their prevalence as age increases, and you see a pretty consistent uptick. When we look at ethnic and socioeconomic variables, we know that at least in the US population, Mexican Americans and non-Hispanic blacks have a higher prevalence. Prevalence increases, as we already said, per decade of age. Males tend to have a little bit higher prevalence. The higher your poverty index, the lower your education level, is predictive of increasing prevalence. And if you were not born in the US, your prevalence is actually pretty high compared to those who were born here. The cat in the household question, this is, I don't know how they must have had a questionnaire with this question and identified that having a cat in the household could actually be protective for unclear reasons. When you look at sort of the age cohort, so the decade at which a patient was born, the birth cohort that is, and we have data from Japan and New Zealand, we see that actually depending on the decade you were born, the prevalence actually goes down. So with the sort of newer generations, the prevalence seems to be decreasing in at least these two populations in the globe. Having more siblings increases your risk of H. pylori infection. Similarly, having a parent who's infected with H. pylori, specifically a mother who's infected with H. pylori, also increases your infection. This is where that short stature sort of, everyone guessed this as the answer, but being taller actually protects you from the infection. So being shorter has a higher incidence of, or prevalence of the infection. Smokers, whether you're an ex-smoker or active smoker, also associated with increased infection. So how is the organism transmitted? So the mode of transmission remains unknown. It's been cultured from vomitus and stool. It's felt that the mode of transmission could be person to person, via fecal-oral or oral-oral, but it's not been confirmed. Other hosts include primates, domestic cats, which is unusual that cats would be protective, and sheep, which is why I had that photo of the shepherd up at the front. Okay, so moving on to how the organism survives the gastric milieu and causes disease. So the organism has to really survive a lot of things to be able to, infect the stomach, and we'll go over how it accomplishes. Gastrointestinal and extraintestinal manifestations of infection, gastritis, which initially is acute, but then in most cases remains as a chronic gastritis, dyspepsia, peptic ulcer disease, gastric and duodenal ulcers, intestinal metaplasia,